Second one is your heart rhythm. Can you name which electrolyte plays an important role in heart rhythm? Potassium, right? Potassium plays an important role in the heart function. Bone and dental health, calcium and phosphate, right? Then nerve and muscle function, sodium plays an important role, right? Then stabilizing the blood pressure, sodium and chloride, right? Then what is the purpose of an electrolyte panel? So if you are going for a routine checkup or any symptoms associated with the to that one, we will do what? An electrolyte panel test. So these are the other conditions where we are going to do the electrolyte panel test. The condition includes what? Burns will be there, severe dehydration will be occurring, cancer condition, dehydrations, diabetes will be there, then cardiovascular, kidney, each one we'll see. Okay. Next one, what are the different electrolytes panel tests you are doing? How many are there? Total 7 are there. It includes sodium, potassium, calcium, chloride, magnesium, phosphate. The main functions also mentioned, right? Now we will go for sodium. Can you tell me what are the main reasons where the sodium level decreases? Hyponatremia, right? What will be the reason? Hyponatremia reasons. Dehydration, right? So what is the normal range? 135 to 145. Variation we can see based on the reference ranges. So if the sodium level is going below 150 or 120, it is a critical case. Okay, there you want to monitor some ECG variations also. You can see if it is going below 150. Next, there are 4 pathogenesis I have mentioned here. What are the 4? Shift of water from the cell, shift of sodium into the cell, retention of water, loss of sodium. Can you tell me whether it is hyponatremia or hypernatremia? It is hyponatremia or hypernatremia? Hypo. Hypo or hyper? Hypo. Can you tell me the first one, shift of water from the cell? It is occur because of hyperglycemia and mannitol infusion I mentioned. How hyperglycemia means diabetes? How it can cause hyponatremia? Why hyperglycemia will cause hyponatremia during diabetes? What is happening? During diabetes, your polyuria occurs, right? Excess urination will be there. There is a chances of removal of excess electrolyte will be there. And also a chance that the intracellular solutes will be shifting into the extracellular. Okay, because glucose is a solute, right? So solute concentration is, glucose is a solute. Because of that solute concentration is increasing, what will happen? The water will be moving, right? So that will increase, that will produce a dehydration which will cause what? Hyponatremia. And second case, potassium loss and retention of water, ADH, right? SIAC, you may have heard about it. What are the reasons for SIAC? Syndrome of inappropriate ADH secretion. What's the use of ADH? Can you name anyone ADH, anyone? Vasopressin. From where it is releasing from? ADH from where it is releasing from? Pituitary gland. Which pituitary? Anterior or posterior? Posterior pituitary gland. Okay, what they will do this ADH vasopressin? What's the function of ADH? Antidiuretic hormone. The diuresis will be stopped. Then what will happen to the water? Accumulation of water will be there. What will happen to the solute concentration? Dilution occurs, right? Then it will goes to hyponatremia. Okay. Then the last one is simple, that is the loss of sodium because of the kidney problem or GI related like vomiting, diarrhea, all this can cause what? Hyponatremia. So here we have mentioned some Possible causes of hyponatremia. Do you saw this anywhere? This wordings. How many of you are there in the fourth year? Which book you are referring for PharmD, clinical pharmacy? Parthasarathi. In the exact Parthasarathi textbook, you can see these wordings. First one is pseudo hypernatremia. What do you mean by pseudo? False rise in the hypernatremic patients. So the examples also mentioned. One is hyperproteinemia and the other one is severe dyslipidemia. Here nothing is going to happen. The water will be shifted. Instead of water, proteins and lipids is going to enter. So what will happen? The hyponatremia conditions. So because of the methods that we are using for the assay also plays an important role in this one. Okay. Second one is clinical fluid overload. As we mentioned in the case of congestive heart failure. The best clinical symptoms, that is one is if the left ventricle is dysfunctioning, means what will happen? Pulmonary edema. The right ventricle is not functioning means peripheral edema. So both the condition, what is going to happen? What is going to happen? Fluid overload will be there. So the solute dilution will be there, which will lead to what? Hyponatremia. The next one is diuretic therapy. What are the ADR of thiazides and loop diuretics? Diuretics ADR? Hyponatremia, hypokalemia, hypomagnesemia and hypercalcemia. That's why thiazide diuretic should not be given in gout patient. Right or not? Gout uric acid deposition also it is increasing. So in gout patient we won't give what? Thiazide. The last one already we discussed, that is the syndrome of inappropriate antidiuretic hormone. So as we mentioned, that is what? ADH secretion is more, means what is going to happen? ADH secretion more. Accumulation will be there, fluid accumulation will be there. That fluid accumulation will lead to what? More dilutions of the solute will be there, which leads to hyponatremia. Next one, the treatment of symptomatic hyponatremia. As I mentioned, if it is going below 115, that we need to treat it. How we are going to treat it? Mainly with hypertonic saline 3%. Still the sodium level is reaching up to 125. But one thing you want to note, that the severe hyponatremia you are treating too fast. It will produce some neurological problem. Okay, so what you want to do, in a 24 hours span, you want to increase only 12 millimole per liter of sodium only. More than that you are doing means it will cause what? Pontine syndromes. Okay, so here how we are going to find out how much amount of sodium we want to give. So sodium deficit is equal to what? Total body weight into what? How much amount of sodium we want? That is 125. Up to 125 we want to raise means 125 minus serum sodium. How much we have? How much we have here? 115. So total body water into 125 minus 115. So how we are going to find out total body water? Weight in kg into the percentage of body water for male is 0.6 and female is 0.5. So you will get the amount of sodium deficit that you can give in the 24-hour span, and you can correct what? Hyponatremia. Here it is clearly mentioned that the serum sodium level increase should not exceed 12 millimole, so milli equivalent per liter in 24 hours. Next, how we are going to find out the different causes of hyponatremia. So the first one, what you want to see? You want to see the serum osmolality. Do you know the equation for finding out serum osmolality? Anyone? If the patient is having hyponatremia, you want to see, first the doctor want to see what? The serum osmolality level. How you will find out the serum osmolality level? 2 into sodium into glucose divided by 18. So you will get a value. That value should be below 285, means the patient is having hyponatremia. So if the osmolality value is below 285, we will tell it as it having low osmolarity and having hyponatremia. Here we mentioned pseudo hypernatremia. Pseudo hypernatremia means what? A false rising sodium will be there. Why it is occurring? As I mentioned, the protein and lipids will displace the water, but actually the osmolarity is correct only. So you cannot tell that it is hyponatremic condition. And this one we already discussed, hyperglycemia and mannitol. How hyperglycemia and mannitol is going to affect? Hyperglycemia, how it is causing? Polyuria, one condition. Another reason? Shifting, because glucose is a solute, so that the excess water will be taken into the extravascular space. So the concentration is going to decrease. Then next one, you want to see the extracellular fluid volume. If the extracellular fluid volume is very low, that will be two conditions. One will be the renal loss, the another one will be extra-renal loss. Renal loss, you want to see the urine sodium level. Okay, so if the urine sodium level is more, if the urine sodium level is more, means what is going to happen? More sodium is eliminating through the urine. What will be the reasons? Drugs. So the drugs are there mentioned: diuretics, thiazide, potassium sparing. Potassium sparing, Joel sir told. What's the example? Spironolactone. What's the idea? What is the idea? Hypokalemia, gynecomastia. Okay. Next, the extra-renal loss other than renal. Here you can, how you will identify? You want to see the urine sodium level. Through the urine, more sodium is going. It will be the reason related to drugs, AC inhibitors, ARB. Whereas in the case of extra-renal, it will be related to other than renal, which includes bleeding, burns, pancreatitis, etc. Okay. So here, if the extracellular fluid volume is normal, what will be the cases? Hypothyroidism. Okay. Then other than that, AI, adrenal insufficiency. What is adrenal insufficiency? Adrenal insufficiency or Addison's disease, I will tell. What do you mean by Addison's disease? Addison's disease. Adrenal gland is going to produce which hormones? Adrenal medulla, you leave it. Cortex, mineralocorticoids and glucocorticoids are there. Aldosterone is there, right? So what is the role of aldosterone? What is the role of aldosterone in renal function? It will reabsorb the sodium and water and excrete the potassium. So what is going to happen in hypo? Opposite is going to happen, right? Sodium and water is going to eliminate, potassium is going to stop. So what will happen to the sodium? Hyponatremia is going, correct or not? So if aldosterone is not there, what is the normal function of aldosterone? They want to reabsorb the sodium and water, they want to eliminate potassium. But in the case of here, aldosterone is not sufficient. So what will be there? What opposite it will happen? Sodium and water will be excessively removed, whereas in the case of potassium will be reabsorbed. And here extracellular fluid volume increasing, as in the case of edema. In which condition edema is going to happen? Congestive heart failure, cirrhosis, nephrosis, etc. Next one is hypernatremia. So in what causes the hypernatremia? Mainly dehydration. How the dehydration is going to causes hypernatremia? How the dehydration? The both it will come. So there is a confusion will cause. How the dehydration is going to produce hypernatremia? The water is excessively removing more than the solute. Opposite also can happen during vomiting and diarrhea. solute also will go, water also will go. But if the solute is going more than the water, it will cause hypo. Here the case is different, that the water is excessively removed more than the solute, then the condition is called as hypernatremia. That's why dehydration is the main cause of what? Hypernatremia. What is treatment for that one? Rehydration. You want to drink plenty of water, or you can give 5% dextrose. Why? Why? If you are giving dextrose, means what is the use? Energy. Hypernatremia, how it helps in energy. We want to solve the issue of what? Hypernatremia. We want to reduce what? Sodium level. For that, if you are giving 5% of dextrose, what is going to happen? No, if dextrose undergoes metabolism, it produces a isotonic solution. This isotonic solution helps to gradually decrease the hypernatremia. We should gradually decrease what? If you are suddenly we are going, means what will happen? It is a problem. So here also, so this is hyper, okay. If it is making hypernatremia, what will happen? The disease called as osmotic demyelination syndrome will be there. Osmotic demyelination syndrome is nothing but myelin sheets are there, right? Where you can see this myelin sheet? In the nerves, mainly in the pons. Pons parallel is there, no? In the pons, the myelin sheet is going to get distracted if you are going to treat what? Hypernatremia, not hypo, okay? Hypernatremia. So we want to correct it slowly. Next one, hyperkalemia. Hyperkalemia means what? Increased potassium, right? So we can classify this increased potassium thing into 3 different things, that is mild, moderate and severe. No need of going into that one. We will just go directly into the causes of hyperkalemia. What are the different causes they mentioned? Renal, medication, tissue damage, metabolic and endocrine. We'll start from the last one. Last one is Addison's disease. Tell me how Addison's disease will produce hyperkalemia. Addison's disease means what? Adrenal insufficiency is going to occur. If adrenal insufficiency is there, means aldosterone level will be less. If aldosterone level is less, sodium and water is going to excrete, potassium is going to accumulate. If potassium is going to accumulate, the condition is what we call it as hyperkalemia. The next one, important, metabolic, diabetic ketoacidosis. What is diabetic ketoacidosis? You guys know. Diabetic ketoacidosis. 40 years, 50 years. During diabetes, this diabetic ketoacidosis is occurring. What is the reason? What is diabetes mellitus? What is diabetes mellitus? Increased glucose level in the blood or body? Blood. What is the purpose of insulin? What is the purpose of insulin? They want to reduce glucose level. How they will reduce the glucose level? By fighting. Allah. They will help in the transport of glucose from the blood into the cell. How they will help that one? The insulin will go and bind to the cell tyrosine kinase receptor. Then the glucose channel will be, GLUT4 channel will be opened. Then the glucose is going to enter. Right? So here in the case, diabetic ketoacidosis, what is the problem? In cell is not getting enough glucose. So what the cell, but the body needs what? Energy. For that energy purpose, what they will do? They will undergo gluconeogenesis. Gluconeogenesis means what? Production of energy from non-carbohydrate resources. Because of that, mainly fat. If fat is metabolized, what is the end product? Ketone bodies. Because of diabetes only, this ketone body is generating. That's why we call it as diabetic ketoacidosis. If insulin level is less, what will happen to the potassium level? Simple. What is the ADR of insulin? Increased insulin is there means what is the ADR? Hypokalemia. Correct or not? Here insulin is less. What will happen? Hyperkalemia. Why it is occurring? Already I told that glucose is a solute. That solute is present in the extracellular space. So all the things will move into the outside area. There the potassium level will increase. So this potassium will come out of the cell. Okay. That's why it is causing. Next one, tissue damage, burns and rhabdomyolysis. What is rhabdomyolysis? Joel sir discussed this one, right? What is rhabdomyolysis? Rhabdomyolysis. It is nothing but the simple muscle breakdown. If muscle is breaking down, what will happen? It will produce a damaging protein called as myoglobin. This myoglobin can damage your renal function also. And also there are some stored potassium and phosphates are present in the muscles. If the muscles is breaking down, the stored potassium and phosphate is coming into the blood, which causes what? Hyperkalemia. Okay. Next one, this one you can easily answer. Who will answer? Why ACE inhibitors causes hyperkalemia? From second year onwards you can answer. Why ACE inhibitors causes hyperkalemia? Think. Why ACE inhibitors causes hyperkalemia? What is the mechanism of action of ACE inhibitor? It blocks angiotensin 2. If angiotensin 2 is blocked, how it is going to increase hyperkalemia? Angiotensin 2 is going to stimulate what? Adrenal gland and starts to produce aldosterone. If it is blocked means there is no aldosterone. If there is no aldosterone, excess sodium and water will be eliminated. Potassium will be accumulated, which causes hyperkalemia. As the first one mentioned, that is simply the kidney or renal excretion problem. If any renal excretion problem is there, what is going to happen? The accumulation of potassium. That's what three things at starting we discussed, where there is going to variate what? Electrolytes. What are the three things? Dehydration, cardiovascular problems, the last one is kidney failure. Okay. Here the severe hypokalemia need what? Emergency or immediate management. First you want to give what? Calcium gluconate for stabilizing. Why we need stabilizing? You need about the potential, action potential. Sodium entering into the cell, we call it as depolarization. Potassium entering into the cell, we call it as moving out of cell, we call it as repolarization. So there is a potential difference is going to occur. If this potential difference is going to occur, what will happen? We want to control that one. For that one, first we will give for stabilizing the resting membrane potential, we will give what? Calcium. Then we are going to give it what? Insulin and dextrose. Why we are giving insulin? ADR. If you are going means it is going to decrease it. Right. So you can see some variations. Where you can see the ECG variation in the case of hyperkalemia. Repolarization, the last phases. T wave, QRS, that area you can see some variations. Next one, hypokalemia. What are the causes of hypokalemia? First one is here. Which drug will increase? Which drug will produce hypokalemia? Just now we discussed, no? Insulin. Insulin overdose. When will insulin? During diabetes mellitus will give insulin, no? So if excess insulin or that unit wise it is not giving correctly, that can lead to what? Hypokalemia. Then next one is renal potassium loss, like the drugs like thiazide, diuretics, furosemide can also produce what? Hypokalemia. The management you can done by two methods. One is intravenous, the other one is oral potassium supplement. If it is not that severe, we will give oral potassium supplement, and if it is very severe, we will give it intravenous potassium replacements. Okay. Next one is hypercalcemia. Hypercalcemia. What are the reasons? We will directly go into the causes. First one is here we will ask something. Which hormone is produced by parathyroid gland? That is thyroid gland. C cells will produce calcitonin. Parathyroid gland will produce which hormone? Very good. Parathormone. When the parathormone is released from thyroid gland, parathyroid gland, when it is going to release? When it is going to release? There is a time when there is going to release this parathormone from the parathyroid gland. When your calcium level is low, the parathyroid gland is going to produce parathormone, right? And when the phosphate level is increased condition also, your parathormone is going to get released. So here what is the problem? Overactive parathyroid gland or hyperparathyroidism. So during that condition, what is going to happen? More amount of parathormone. If more amount of parathormone means what will happen to the calcium level? It keep on increasing, which causes what? Hypercalcemia. Okay. Next one, too much vitamin D. Why? What is the role of vitamin D? Calcium need to absorb from the gut. For that we need what? Vitamin D. About too much vitamin D means too much absorption of calcium, which causes what? Hypercalcemia. And cancer related things are there, mainly bone cancer. All the cancers you can see this condition that the minerals level is being, the electrolytes liver variations. Okay. Another things, tuberculosis, sarcoidosis, thyroid, CKD, adrenal gland. Here the tuberculosis and sarcoidosis, how they can cause hyperkalemia? Can anyone tell? It is going to affect one mitochondrial enzyme called as alpha hydroxylase, extrarenal one, alpha hydroxylase, which is very important for the conversion of vitamin D. Vitamin D, another name, main name? Cholecalciferol. Very good. This cholecalciferol is inactive form. We want to convert into the active form called as calcitriol. That is done with the help of alpha hydroxylase. So what will happen? More amount of calcium will be there. Okay. So which will leads to hypercalcemia. Then reduced mobility. Reduced mobility will increase. Reduced mobility means what you guys are doing, we guys are doing. We want exercise. Instead of that, we will chit chats in the mobile and sitting simply. If you are sitting simply for a long period of time without doing any activity, they are telling that it will cause what? Hypercalcemia. Why? There is a variation occurs in the osteoclast and the osteoblast. Osteoclast activity will increase, which means destruction of the bone will occur, which releases plenty of calcium into the release. So calcium level is going to increase. Osteoblast means new bone formation. So that activity is being stopped. So new bone formation is not occurring, but bone damage is keep on occurring, which will cause what? Hypercalcemia. And medications like what? Lithium. For lithium, why we are giving? Which condition? Bipolar disorders. So this lithium drug can also increase what? Hypercalcemia. Some complications, because if calcium is increased, what are the complications? Osteoporosis. Why? More calcium is good now. Because this calcium is present in the blood. Resorption of calcium from the bone occurs. Because of that, osteoporosis it will get. Then kidney disease, kidney stone, renal calculi, and the last one is irregular heartbeat. Why we need calcium for? Contraction. Right. Treatment. The last one we want to see. Only two, calcitonin and bisphosphonates. What is calcitonin? Hormone. It's a man-made hormone also is there. What we can take. What is the role of calcitonin and from where it is secreting from? C cells of the thyroid gland along with T3 and T4. When it is released? When the body is having high amount of calcium, so that the calcitonin can reduce the calcium level. Okay, that's why we are giving in the treatment of hypercalcemia. Another one, this one, bisphosphonates. In which condition we will give this drug? Osteoporosis. Here complication is osteoporosis. If you are giving bisphosphonate, phosphates, it is also present in the bone along with the calcium. Okay, so they will form complexation. Okay, next one is magnesium, hypermagnesemia. When it will happen? It is a very rare scenario, and like magnesium, Epsom salt you are taking like that, but it is not regular things. Or treatment means you can give calcium gluconate and diuretics. Next one is hypomagnesemia. When it will cause increased excretion of magnesium when you are drinking too much alcohol. Because if you are drinking alcohol, it acts as a special diuretic ability to the magnesium, which will excrete plenty of magnesium from the body. So that another one, protracted diarrhea. Protracted diarrhea means daily you will have 4 episodes of diarrhea continuously for 14 days you will have. So what will happen? Electrolytes will go. So that condition also you can see. And another one here, diuretics already we discussed. This will produce hypomagnesemia. Another one, the breastfeeding woman will have sometimes they will have a less amount of magnesium. Why? Because they are excreting some amount of magnesium through the breast milk. Okay. Next one is phosphates or phosphorus, hyperphosphatemia. 3 things are mentioned here. One is 4 things: transcellular, decreased excretion, increased intake and absorption, and pseudo hyperphosphatemia. Decreased excretion. First one is renal disease. Second one, hypoparathyroidism, pseudo hypoparathyroidism, bisphosphonate therapy, then intracellular insulin deficiencies, then acidosis, rhabdomyolysis. We discussed this one, right? Rhabdomyolysis. Why? Breakdown of muscles and release of things. Next one, increased intake and absorption, hypervitaminosis D. Why? More vitamin means more calcium. More calcium means what hormone will reduce? What hormone will produce? So, okay. So here another one, pseudo hypothyroidism. We discussed multiple myeloma. What will happen? The water will be replaced with the help of protein and the lipids. There also chances are there. Next one is hypophosphatemia. So here transcellular, same recovery phases of diabetic ketoacidosis will be there. Refeeding syndrome if you are not eating the food for continuous period of time. Okay. Then increased excretion can be GI related, renal related, hyperparathyroidism. How it is going to affect? Hyperparathyroidism. Hyperparathyroidism means what? Parathormone will be more. If parathormone is more means more calcium level, potassium level is low. Okay, same thing. Then malabsorption will be aluminum, magnesium, salts are you are taking. Okay, those things. Then metabolic alkalosis and acidosis. Here metabolic alkalosis means simply but the reduced bicarbonate level in the blood. Alkalosis means what? Decreased bicarbonate. Acidosis means what? Increased level. Can you name one drug which causes acidosis? Joel sir told. Hey, you answered, no? Metformin. Metformin will cause what? Lactic acidosis in the cases of here normally in the metabolic alkalosis, the alkaline containing things like what? Antacids, baking soda, the diuretics, and even steroids. Steroids, why they are causing metabolic alkalosis is nothing but the bicarbonate reabsorption will be more in the case of steroids when we are taking steroids. That's why it is causing metabolic alkalosis. Okay. So just brief things I have told about what electrolytes. So when you are going for ward rounds, you want to keep already, you know that 40s, 50s, we discussed these things. So when you are going to ward rounds, what you want to do? Just take the laboratory data interpretation. You want to take it seriously. So you want to see which drug is actually related for each one. As sir told, isoniazid rifampicin, what it will produce? Sir told no. Liver enzymes. Atorvastatin sir told. Isoniazid can increase the SGOT, SGPT level. So we want to monitor it. All the tubercular patients, if you are giving the drug, we want to monitor it in the phase of the 6 months, 9 month period. For longer period, we are giving that drug. So there is a chance of liver function variations will be there. Okay. So those things you want to take care when you are seeing this electrolytes. And whenever you are going to check the renal function test, you want to see the electrolyte level also. So you will get a clear picture. Okay. So next we will go with the last one, that is the renal function test. So renal function test, what are the usual tests we are going to do in renal function? Serum creatinine, then serum urea we will do, then blood urea nitrogen we will do, then usually which one we will see? So many tests are there, including urine analysis, odor, color, pus cells we will see, Cas cells we will see, then creatinine. Why we are taking this creatinine so importantly in the case of renal function test? End product. What end product? This gym people. When they are going to gym, they will take what? Creatinine or creatine? Creatine. What is the difference between creatine and creatinine? Creatine is a triphosphate, ATP, adenosine triphosphate. Phosphate is required for the generation of energy. So more amount of phosphate is there in the creatine. It is metabolized into or activated into what? Creatinine. Okay. So the muscle mass metabolism occur also, that time also creatinine will be there. But why we are taking this creatinine as a marker for renal analysis or renal function test? Why we are taking? The 99% of this creatinine is eliminated through the renal system, and only a 0.5 or 1% is reabsorbed by peritubular capillary. So it is a best marker that you can identify what? eGFR. What is eGFR? Estimated glomerular filtration rate. Okay. Which equation we will use for that one? Fourth year. Which equation? Fourth year. Which equation we will use to find out creatinine clearance? Cockcroft-Gault equation. What is that? What is the equation? 140 minus age in years into weight in kg divided by serum creatinine into 72. If female means 0.85 will add. So if you are finding out the creatinine clearance, it will give an exact idea of what? GFR. Okay. So we'll see this one. Kidney mainly produce what? Some hormones. It helps in the production of RBC. It helps in the production of vitamin D. What are the hormones that the kidney is going to produce? Aldosterone. Hormone. Renin. You heard about renin? Okay. Then RBC production will be there. Vitamin D production. So all it is controlled by what? Kidney. Next. In which condition you are going to do a renal function test, or when you are going to, or when the doctor will prescribe a increased condition. So serum urea is increased condition, might be hypermetabolic condition. Why? Starvation. If you are not taking food properly, what will happen? Excess protein metabolism. So excess protein metabolism means excess urea will be there. So increased urea will be. So we cannot tell that it is because of kidney only. Okay. Decreased means hepatic injury. That is that also we want to see what creatinine level also. We want to compare it. Simply you should not tell. Next one is creatinine. Blood urea nitrogen. Okay. What you want to do? Just simply that urea level into 0.47 you are doing means you will get a blood urea nitrogen. That to decrease the condition means what is there? Same like fluid overload will be there, malnutrition, severe liver problem will be there, CR. CR means what? Syndrome of inappropriate ADH secretion. That condition also you can see. Increased means renal functions. Next one is serum creatinine level. What is the normal range of creatinine? 0. One question. Always if creatinine level is increased, can we say that it is due to kidney related problem only? No. Then other cases? This supplementation those who are taking and those who are going strenuous exercises also, there is a chances of increased creatinine. Okay. Some drugs there to elevated level, trimethoprim, cimetidine. Okay. And also this creatinine level, that is 50%. If any renal function that is damage occurring more than 50% only, but there is, you can see a serum creatinine elevation. By that time, a 50% damage may have done. Okay. So here they have mentioned about, have you seen this one? 40S. It's the modified diet in renal disease and CKPD EPA. This is two another equations which we use other than what? Cockcroft-Gault equation. Why? Because this Cockcroft-Gault equation is not valid in patients who having reduced renal function. Why? Because only creatinine we are looking means renal failure is already there. So that equation won't work. So we will change it with what? We will include the race, age and gender variation into this equation, and we will use this equations, MDRD equations. Usually for other normal patients we will look after with what? Cockcroft-Gault equations. Right. Then next, using creatinine clearance you can find out the different stages of what? Creatinine clearance. The creatinine clearance you are getting 90 to 120 range. What it does? What it means? You having a normal function. If it is going below the stages, stage 1, stage 2, stage 3 like that, you can see the reduced rate, right? So these are the main renal functions what you are seeing. So what you want to look after in renal function? Mainly serum creatinine and serum urea, and also you want to keep an eye on the ratios. Always they won't do, but if you are increased means surely you can tell that that is the patient is having a renal related problem. Okay. So what you want to do means when you are going for ward rounds, you want to take care of what? Laboratory data interpretations. Okay. Thank you.